We'll move now to item number 1, Senator Mendoza, who just left. Senator Hernandez. Item number 3, SB 323. Good afternoon, Senator Hernandez.
Well, good afternoon, Mr. Chair and members. Thank you very much for allowing me to present on the bill this morning. The Affordable Care Act just placed 4 million individuals in our healthcare system that, as we all know, is already struggling to meet California's needs. As you know, we have a shortage of physicians here in California. Study after study highlights this fact, including one released just last month by the Association of the American Medical Colleges that says, demand for physicians continues to grow faster than supply, leading to a projected shortfall of over 90,000 physicians by the year 2025. Here in California, just 16 out of our 58 counties have the recommended ratio of physicians to residents. Additionally, 1 in 3 residents in our state receives care from our Medi-Cal system, where wait times to see a physician can be as long as 9 months, and health plans are struggling to comply with network adequacy requirements. We can no longer afford to get by on a fraction of our professional capacity. California needs more healthcare providers practicing to the full extent of their training so we can all access this system efficiently. This bill, SB 323, is a simple and modest policy that is long overdue in California. This bill does 3 things. It establishes a uniform scope of practice for nurse practitioners that is widely agreed to be the services that they already perform today. The second thing it does, it explicitly requires nurse practitioners to refer a patient to a physician or another licensed healthcare provider if a situation or condition persists that is beyond the scope of practice of their training. And third, it grants the NPs the ability to practice outside a physician-directed standardized procedure if the nurse practitioner is certified by a national certifying body, maintains professional liability insurance, and is practicing in one of the following settings. And this is what changed from 491 several years ago: a clinic, health facility, or county medical facility, and accountable care organizations, or a group practice. You will hear from the opponents today that say this bill will put patient safety in jeopardy. The truth is that there are over 30 years of evidence in the 20 states that already allow full practice authority that all say the same thing. When patients see nurse practitioners, patients' outcomes are equal to their physician counterparts, and patient satisfaction is generally better. Opponents will likely offer many anecdotes to personal stories to make their point about patient safety. However, if this policy puts patients in harm, we would see some evidence of that in other states. But there's no evidence of that. They don't have any data to back up their argument. You will hear from opponents today for granting nurse practitioners full practice authority goes against the team-based coordinated care and will further fragment the healthcare system. Let me tell you, nothing is further from the truth. Healthcare is transitioning to a team-based approach for everybody. This bill will do nothing to change that. We have crafted this bill to ensure that nurse practitioners with full practice authority are practicing only in team-based settings. That is one of the reasons that CAPG, who are the leaders in advancing coordinated care in our healthcare system, are strong supporters of this bill. They would never support anything that moves healthcare towards fragmentation. You will hear from opponents that NPs order more tests and can be more expensive than physicians. If that's true, then health plans won't contract with them and medical groups won't hire them. In a world where 3/4 of our care is delivered through capitation systems, and believe me, when you're dealing with a capitated system, there's going to be a lot more tolerance to waste. Please join me with Assemblymember Eggman, hospitals, clinics, health plans, physician groups, large and small businesses, labor, consumers, academics, universities, seniors, and a broad array of healthcare providers in support of this measure approach to full authority for nurse practitioners. 18,000 of them are here in California and stand ready to help. So with that, members, I ask for your support And I have also with me individuals who would like to speak in support of the measure. Thank you, Mr. Chair and members.
Thank you, Senator Hernandez.
Good afternoon. Christy Weiss on behalf of the California Association for Nurse Practitioners in Support. The analysis does an excellent job of clarifying how the physician supervision mechanism exists currently. And it's important to note, as is called out in your analysis, that that supervision is not direct, it's not physical. It doesn't even require that the physicians have to be in the same facility where the NP is practicing. So I think there's this misconception that the senator's bill would, take the physician out of the room. I think it's important for purposes of our conversation to keep in mind that the physician is not in the room now. So with that, I'd like to introduce our nurse practitioner, Kathy Ware, who's here to make a few comments and answer questions. She practices locally in Sacramento.
Thank you, Christy, and thank you, Mr. Chairperson, and all of the committee members. My name is Kathy Ware, and I'm an adult nurse practitioner. I work across town at UC Davis Health System. I'm certified as an adult nurse practitioner and a cardiovascular nurse. I'm also a tobacco treatment specialist, and I work in the Vascular Center Clinic. I'm here today as the health policy chair also for this California Association for the Nurse Practitioners in strong support of Senator Hernandez's bill. This bill would remove unnecessary bureaucratic language that is causing the nurse practitioners working in the state of California to that are providing excellent care, safe care, to be able to providing unneeded barriers to the practice of nurse practitioners taking care of patients every day in California. Sorry, I'm a little nervous. I'll just look at my notes. The essence of being a nurse practitioner is collaboration. The senator made very clear that this is a team-based approach to healthcare. We need that. The patients that we serve, the families and communities that we serve need a team. The physicians that I work with, I work in an interprofessional practice, which includes myself, nurses, surgeons, cardiologists, and radiologists. Each of us are practicing as we are trained and educated. And when I am taking care of a patient, I am providing direct care. I have my own template. I take care of my own patients. And if a situation arises where I determine that the patient needs care beyond what I can provide, I call the surgeon or the interventionalist right away. This is how I've been practicing for years. This is what nurse practitioners are doing all across the state. So I would also like to say that and piggyback on what the senator was saying about the access issues. We care for patients all over the state that are in rural and underserved areas, and we'd very much, 21,000 nurse practitioners in the state would very much like to be able to increase access to provide care for all of the patients who need it in California and who deserve quality care. And I'd be happy to answer any questions.
Ms. Ware, I have a question on
Yes.
You mentioned, and it's just more for clarification, I guess, and for members too. And my understanding is that in your comment, you provide care until you reach the point where it's beyond your ability to provide that care. So you have currently a scope of practice within which you can provide that care, and you know, and this is kind of the question, you
Yes.
know at what point you're exceeding that, where you then rely on the medical profession or call a doctor for assistance or whatever other services you would need beyond that. Is that?
Yes, that's exactly
occurs?
correct, and thank you for the question. My education and training and my clinical experience, in my particular setting, I provide chronic disease management, wound care, risk factor modification, prescribed medications when needed. However, if a patient who has severe vascular disease, blood vessel disease, needs to have an intervention deemed by my assessment and my analysis of their diagnostic studies and so on, I would then refer immediately to the surgeon or the interventionalist to perform the surgery or intervention that was needed to improve the circulation, and then I would then follow up with the patient later to do the wound care. So yes, I'm trained and educated to do all of that, and what we're taught in school and what we do in our clinical practices is we know what we know, and we know what we don't know, and we refer immediately when needed. And this bill would really not change that, but because this is what we're already doing. But it would help codify some of the arduous language that's putting barriers up that are unnecessary for care.
Very good, thank you.
Senator, if I could just add to that, for all nurse practitioners, if they engage in a practice that's clearly beyond their education and training, their license is on the line, and the Board of Registered Nursing would be, responsible for enforcement and taking disciplinary action against them.
Very good, thank you. Other witnesses in support?
Yes, Senator Hill, committee members. I'm Alan Siefken. I'm here to support SB 323 as an excellent first step in expanding care delivery potential for the people of the state of California by allowing nurse practitioners to work and practice to the full extent of their education and training. I'm a retired internist. I'm an ICU physician. I'm a pulmonologist. I've been on the UC Davis School of Medicine faculty for 40 years, and for the last 22 years I've been Chief Medical Officer at the UC Davis Medical Center. I just retired this last year, so I'm speaking on my own behalf today. I've worked directly with nurse practitioners in numerous practice settings in my practice over these last 4 decades. These include not only our adult and family and community nurse practitioners and pediatric nurse practitioners in the primary areas, but orthopedic, neurosurgical, trauma, cardiac, cancer, GI, pulmonary, a wide range. I've had the ability to see their ability to diagnose, manage, and they do it in an outstanding manner. I've also had an additional advantage in working with them and observing the multiple roles that they play in quality and patient safety initiatives, working both in nursing peer review, which is something that's very important and brought up in this bill, and in their participation in our own medical staff committees and initiatives. Clearly, they're integrated into practices and they are part of the team. I need to emphasize 3 very important points on this proposed legislation. First, there is not an issue of patient risk or harm as nurse practitioners continue to work in the fields and areas in which they've been working. There's no evidence in those states where nurse practitioners have had expanded scope of practice that there is any new or increased patient quality of care, patient safety issues that have been identified. There is no founding to this statement. Number 2, the current bill proposes that nurse practitioners work for or within an organized system or medical group or a health system, and this will very much strengthen the guarantee that their practices are integrated. The term that's been used, and you will hear today about independent practitioners, these are individuals who, as nurse practitioners, by their very nature, work as part of the team and have done so and will continue to do so. But the language that has been put into this bill will assure that that must continue to do so because of the requirement that they're within an integrated practice. Any concerns regarding professional liability coverage or oversight can be addressed, if necessary, by even adding that into this bill. But by the very fact that they're going to be required to be part of an integrated organization or a medical group, the issues of medical malpractice and coverage is in fact addressed. The third issue, I think, is the greatest opportunity for the people of California, and that is to the extent that nurse practitioner practices have not currently been part of an organizational's peer review or quality and safety measures. And I'm saying that isn't true. In many cases, like our own at UC Davis in the past, when I was chief medical officer, we very actively did nurse peer review to look at their practices. But to the extent that that hasn't occurred in integrated organizations, now this legislation would create an opportunity, and I believe an absolute mandate, that their practices are reviewed in this manner. And that's what's very, very key about this. We, in fact, can even bring to a higher level of accountability our nurse practitioners' practices. We know that they work well in teams as leaders and followers. And this is really important because in integrated medicine, you got to be able to both lead and follow. You just can't be a leader, you just can't be a follower. They have very special skills in patient education of both the patients and their families. They have very high, you've heard already mentioned, documented levels of patient satisfaction and long track records of working with physicians. Why would there be any reason, should this bill either pass in its current state or amended state, that they would work in any less of an integrated role. There's really no reason to believe that changing their current practice will do anything but to embed them more firmly within the healthcare delivery system. This proposed legislation does raise two questions and opportunities, which were addressed by Senator Hernandez. Will there be expanded coverage into areas where we lack currently care practitioners, particularly in underserved rural areas or urban areas? This opportunity really exists, and here is an opportunity where we need new practitioners. Do we know for sure that it's going to occur? No. Why has this been a problem? You know, around this table, it has to do with poor payer mix, special social, economic, demographic, language barriers. Those are going to continue whether you have a nurse practitioner or a physician or a pharmacist or anyone else delivering that care. But it gives us a great opportunity. Number two, will there be a reduced cost of care? We don't really know until we actually measure it in California's reimbursement and cost models. But that was so accurately pointed out because of the way in which California is now reimbursing for care and the way both federal and state government is moving forward in a prospective and other cost basis. There's no reason to, in fact, employ and hire any provider, be they physician, nurse practitioner, or anyone else, if they can't do it in a cost-efficient manner and we can't measure their, in fact, improvement. And so there lies the ability for us to move forward, measure improvements in their quality of care, to mandate whether they have increased patient safety problems and what their costs are, and that has to be an important corollary to this bill. So I thank you. I strongly support this as the next step of one of our processes for improving care for Californians. Thank you.
Thank you very much, Doctor. Yes, Senator Jackson.
Yes, if I may, before you leave, because there's a long line of folks who would like to say a few words, I'm sure. You talk about the bureaucratic, how cumbersome it is now, the bureaucracy. What is it that's required and why is it cumbersome?
Well, the supervisory language puts in, barriers for nurse practitioners to provide care in the current settings. For example, in the requirement for supervision, for example, one of my colleagues that works in Southern California, she cares for 6,000 lives. She's a women's health provider, and she employs a physician to be her supervisor to comply with the law. However, that physician is now going to be leaving, and if she can't find a replacement, then she will have to close her practice because of the supervisory language. As I've already mentioned, and Christy mentioned also, supervision is not direct shoulder to shoulder right there. We rely upon each other, physicians and nurse practitioners alike, to provide the care the patient needs when they need it.
Okay, so if that, what I hear is that we are at risk of losing the physicians to do the compliance, if you will, the oversight, whatever you want to, however you want to define it. I'm wondering, though, you mentioned, Doctor, and thank you for your very articulate presentation, and I also want to thank Senator Hernandez, who explained this at some length to me today, and I appreciate the time he took. But I articulated then and earlier just the concerns I have. There's a reason people are doctors, and that's because they've got this theoretically this wide range of experience and training and so forth. And, you know, nurse practitioners don't quite have the same amount of training. So that makes me wonder, is the level of care going to be as you know, the kind of quality that people expect when they go to a doctor, when they go to a clinic? They've got an issue. They don't really care, you know, who takes care of it. They just want it taken care of. So how do we assure? I mean, you've got different levels of education. One's a MD, the other's a nurse practitioner. That difference between the physician and the nurse practitioner, what I hear you saying is there really isn't a difference. A nurse practitioner can do it as well. Is that an accurate statement?
Senator Hill, may I address? Sure. Physicians are trained as physicians. They have a track in which they originally learn about their art and then eventually by practice and experience become much better at it. Nurses are the same. And those with advanced practice degrees who become nurse practitioners, those that have masters, PhDs, they have a learning and then they continue to grow and have an experience as a result of their practice as nurses. Physicians and nurses are not the same. When you put your hands like this, I wasn't sure whether you meant the nurse was here and the physician was here in some areas, or the physician was here and the nurse was here in other areas.
I'm asking you.
But that lies the truth. I mean, my comments about education and dealing with the patients and perhaps continuity of care sometimes are done better by a nurse practitioner than a physician. Some of our physicians are tremendous, and they are global people, global thinkers, and their practices all the way up until they die or retire continue to be that way. Many, many more of our physicians, because how difficult it is, their practices become more and more narrowed. And as a matter of fact, they don't have all of that same giant skill set 30 years after their practice, or even 5 or 10 years after their practice. Our nurse practitioners may be that way too, if they're very focused in being cancer only. But the truth of the matter is, if you're an individual who needs care, and you do not have access to that care provided by a nurse practitioner, you will get very good care generally. You will get very good care if you see a physician generally. But to say one will be better than another depends upon the practice circumstance, the reason why they're being seen, the issue that's involved, whether it be chronic case management versus an acute intervention. There's a lot of differences. So I wouldn't generalize to say that one was better than another.
I'm sure our doctors will not be happy to hear that. But that being said, I'm not taking a position one way or the other on the accuracy of that, and you have practiced for many years, so I don't doubt the statements you're making. What I'm wondering is why the notion that we have nurse practitioners operating independently, and yet what you're saying is that they are part of an integrated practice. Could you explain the distinction there? Because either they're independent or they're not, and unless I don't understand the definition of independent.
Senator Hill?
Yes, of course.
Independent, I believe, is a tough word here, because it puts in people's minds that, in fact, you're somehow out there working on your own and you don't ever deal with anybody else on an issue. And the truth, that couldn't be further from the truth with almost all practitioners working in the state of California now. There do exist small numbers, vanishingly less, in rural and other portions where they don't ever work much with other docs. And the same thing with our nurse practitioners. But this legislation, as currently written by Senator Hernandez, requires that they work with or be employed by a system, either a medical group or a health system, which in that language can be improved upon if there feels to be a need to define that better. And that then makes sure that there isn't an issue of they're not being able to work within the group and the team the way that they're currently working now. You heard there is the issue of independent alone, I think, is a problem, and that may be the issue that you're dealing with, because our nurse practitioners, they in fact always work with the patients and the family and then get additional assistance as necessary from whoever else in the medical community they need, specialist or a general internist.
So we then are relying on them to go to whomever they need, that they feel they need to go to get that assistance.
And that's been their training, and that's been their practice. And so yes, we're just like you're relying on your physician who you see in the office to in fact send you to someone else if necessary, or to keep and manage your problem alone if he or she feels he or she can do it themselves. So you
think that I should, if I have to go to a physician, I should be able to feel as comfortable going to a nurse practitioner for that, with that same situation?
It would depend upon the situation. If I was going to have vascular lesion, an AVM embolized in my leg, I would want to go to a physician who could do that. I wouldn't want to go to a whole lot of other physicians who could not. But for the management of my general health care and my initial diagnosis of my children's disorders or my adult disorders and my hypertension and chronic disease management and diabetes, et cetera, stepping into the office with a well-trained nurse practitioner will give you good care.
Well, because you say here that this giving the nurse practitioner the ability to assess patients, synthesize and analyze data, and apply principles of healthcare. So are we giving them, and then it talks about establishing a diagnosis by client history, physical exam, and other criteria. So
Let me yield to people that do that every day.
yeah, go ahead.
Yeah, so our training is to, let's just say I'm working in a primary care setting, which I have done in the past, and a patient comes in and they have a complaint. I take a history, I perform a physical examination. This is exactly what my physician colleague would do. Based on the history and physical examination, I then develop a differential diagnosis. That means a list of stuff it could be. Top of the list is what it most likely is, and going on down to what it probably isn't, but you keep it on the list. Then you order, if needed, diagnostic tests, perhaps imaging, perhaps labs. You get that information back and you put it all together and make the diagnosis, and the diagnosis drives the treatment. If this is, let's say you come in with belly pain, I examine you, I think you got gallstones, I get an ultrasound, you do have gallstones, I send you to a surgeon. If you come in and you have belly pain and it's because you have reflux, I'll give you a pill for reflux and follow you up. So it's based, the crux of medicine and the crux of what nurse practitioners do is make that diagnosis, and that's based on our training.
Without consultation with a physician?
What I just described to you, I would not need a physician for that. That's my training.
Well, what if you thought it was gallstones and it wasn't?
If I thought it was gallstones and it wasn't, then I'd go back and say, okay, it's not gallstones, it's belly pain. So let's look at the labs. Maybe there's something wrong with the pancreas. Maybe, I mean, you go through the whole list of what it could potentially be until you find the diagnosis. If let's say on that initial visit, I didn't find the diagnosis, I would then consult, of course, with let's say a GI specialist to find out, to drive further diagnostic procedures or to drive further treatment planning in order to come up with the right answer.
Well, so what you're saying is that you're going to be I hate to say the decider, with all due respect, as to healthcare without going to what is at least theoretically the next step up, which is the physician. Is that what you're?
But I think, Senator, if I may, that's the way nurse practitioners are educated and trained to practice now. That's the way they're practicing in 21 other states. That is the model. When they go through their advanced training and their clinical rotation, they are educated and trained to see patients and treat them in the way that both Kathy and Dr. Stupkin, described.
And I understand that. I'm not questioning that you're well trained. Where I'm stuck is the notion that you could actually also, if you are in any kind of a clinic setting or a health facility, also have a consultation with the physician, but that this is going to take away the need to do that. Isn't that right? Isn't that what this legislation does? It doesn't take away the responsibility to it makes
if I may
it
answer that,
voluntary,
what it does,
not?
it does not require the oversight signature, which is essentially the review that she's talking about. That's the only difference. In fact, built into Mr. Hernandez built into this, that in fact, if there was a lack of a clear diagnosis or knowledge, that in fact a consultation should be obtained. That's actually built right into this. But that's part of the standard practice anyway. I don't think there's anything new or different, but I think that that's been put in to in fact allow for individuals reading this to feel more comfortable about it.
So we're saying you're taking away the oversight, but requiring integration. Is that right? No, there's not going to be any oversight, but there will be integration.
If I may answer that,
of course.
By the very fact that the nurse practitioner, along with your physician, whether they be a family doc, an internist, a pediatrician, everyone in California now is practicing in some integrated model. You can say, well, that's not true. There's the doctor in Modoc County who's practicing on his own that isn't in any IPAs, any group at all, just makes it on his own. That's absolutely true. But the vast majority of physicians in this state are practicing in some sort of a model with other practitioners. And just because of that, they in fact have oversight, and they are having greater and greater amounts of required review. And that's the opportunity here that this legislation gives us to, in fact, assure that we're looking to see whether there's a change in access, there's a change in quality, there's a change in patient satisfaction. That has to be done. If you're going to pass this in the state of California, you've got to turn around and see if there's any issues. There haven't been any issues in the other 20-plus states in the United States, but we want to look to make sure that there aren't. But by embedding, requiring that they're integrated in part of an organization, you're going to have that oversight.
Okay, well, thank you.
And if I could just ask, and maybe this is a little clarification as well, and it's where you were talking about that, you know, you're, for lack of a better way of explaining it, you'll try one diagnosis thinking it may be this based on your experience, the testing that you've done. If that doesn't work, you'll try something else, and then if it gets to a point, you'll go to a physician to do that. And I guess my experience has been, I'll go to a physician with a particular ailment, complaint of some kind, and you know they'll do different levels of testing to determine what it is. Usually the least invasive first, and then get to the point where they have to. And so I don't see a difference really, unless I'm missing something, of the level a physician would try certain tests to see whether this meets that particular protocol and that diagnosis, until he gets it right, and then try something else. And what I'm hearing is you would do the same thing at your level of experience, which is at that basic level would probably be the same as a physician would be doing.
That's exactly right. Thank you for that.
Okay,
That's exactly what I would do, and that's what nurse practitioners do.
Good, thank you for that. Appreciate it. All right, I see we have a number of people for support, so if we would just allow you to just make some brief comments and your name and who you're with. And before I have to leave in a minute or so for a few minutes, so before I do, I just wanted to clarify something, and Senator Bates will have the gavel and chair the meeting for a period. You did accept, you are presenting some amendments of authors' amendments that you're bringing up to clarify some of those issues that were raised. Is that true? Okay. And then I would, if the bill moves forward today, if you would consider that the nurse practitioners, as it moves, could comply with the peer review issues as well as conflict of interest issues that currently physicians apply to physicians. Is that something that would work, and those provisions are applicable today to physicians? Just like to see them apply there too.
I'd have no trouble to address or look at them, but we'd obviously like to look at the language as well.
Yeah, of course. Very good, thank you.